this will be my last presentation with this institution, as I'm going to be moving forward and starting as an assistant professor at Jefferson University in Philadelphia next week. And I want to present this interesting, I call it my ACS disaster case, intra-abdominal sepsis. And this is a 47-year-old female. She has been treated 2 months for mild colitis, treated with steroids. Actually, a week before she came to the hospital for this presentation, she was in the ER. She had the belly scanned and they increased her steroid dose. Now this time she comes tachycardic, hypotensive, lethargic, hypothermic, a blood glucose of 16. This is the lowest I've seen in my life. She was admitted to medical ICU for presumed dehydration. She was started on D10, crystalloid infusion. Her potassium was being monitored because her K was 5.9. She was started on broad spectrum antibiotics. She required pressors. Her lactic acid was 12. She had a gap of 20. Coagulopathy. Her other past medical history and surgical history includes rheumatoid arthritis. She has known ulcerative colitis and HIV. She had the Roux-en-Y gastric bypass laparoscopic in 2008, and she had a colonoscopy in 2017. Other than that, pretty unremarkable family and social history. This is a chest x-ray that was done around 3 a.m. in the morning when she came to the ER, and by Nighthawk radiology, it was not picked up or read that this is actually free air. It was, I guess, more interpreted that this is kind of how the lung goes, more posteriorly, but this looks clearly free air. And she is now hospital day 1, basically 6 hours within her admission in the medical ICU. She's still tachycardic, blood pressure is a little better. She's complaining of diffuse abdominal pain. Her platelets were down to 61. Lactic acid improved a little. 20, create up to 4. The medical ICU physician contacted me and he said, I'm getting a KUB and a CT of the abdomen and pelvis because I'm concerned that something is going on with her. And that surgery was contacted. You can see on the KUB how this line here basically represents the free next to us, and this is also a little bit definitely concerning for free air. And then the CT scan shows her anatomic changes from the Roux-en-Y gastric bypass, massive amount of free air. And then this is contrast from her prior CT scan done a week ago, okay? The CAT scan, and basically with this information, I took it to the operating room. I performed exploratory laparotomy. I found pneumoperitoneum. There was purulent contamination in her abdominal cavity. There was marked inflammation of the cecum and ascending colon. Terminal ileum was thickened, and there was a perforation with abscess in the distal terminal ileum, where I put this arrow here close to the ileocecal valve. So how would you address surgically these findings, and would you do damage control abdomen, or would you close the abdomen at this time? And if you choose damage control, what device would you use?
Dr. Untrak in Iraq, your comments, please.
Yes, so this is really some case. I mean, a lot of complicating features. So this is her first day in the hospital. Is that right? Did I get that right?
Yeah, she's within the first, by now, 7 hours within the admission. Yeah.
Okay, and her platelet count was how much?
61.
Okay, so I don't know that I would have spent time with all those other studies. I would have gotten the infectious disease and the AIDS specialist there to let us know what we needed to do with a CD4 count of 20. So it sounds like she wasn't taking her AIDS medicines perhaps, or was lost to follow-up. And so I think she's at probably at very high risk for anything without lower CD4 count. So I would consult those two right away for, probably she would just get 3 antibiotics to cover anaerobes and gram negatives. And I don't know that the HIV specialist would recommend anything acutely, because it was, you need to take her to the operating room, but I would still ask them. And I probably would have operated based on that one film, and her exam was probably clear that she had an acute abdomen, I take it. Is that right? Dr. Alex?
Yeah,
Yeah, I think he's frozen. But anyway, my initial thought was a ruptured toxic megacolon, and I thought you would go in and find you had to remove the whole colon. But I would certainly do the smallest procedure possible and exteriorize that perforated segment, or perhaps, depending on, and I wanted to ask about the again, the cecum and ascending colon, if it would look severely inflamed and because it's limited, I might, and her infection is so bad, I might actually do a limited resection of the just proximal to the perforation and what looks like less inflamed terminal ileum up to the beyond the area of inflamed woody colon, then bring the two out together as a single stoma, sort of like a miculate stoma, just exteriorize them, and then wash out the abdomen very thoroughly, extensively, in all the spaces, and then get her back to the ICU without keeping it a very brief operation, but be sure to really clear the abdomen of all contamination, and then address her underlying medical problems.
Thank you, Dr. Untrack. Portland, Dr. Kasim, your comments, please.
You're right, Alex. This is a disastrous case to begin with. So I have a little different thought on the management of this case. I think before you rush the patient to the operating room, you got to do a very thorough resuscitation of this patient. Anybody can operate on a patient like this, but if you don't have all the ducks in the row with resuscitation, you're not going to get a very good outcome. So I'm hoping that when Alex got involved, he got everything resuscitated properly and the patient in the operating room. Now she's in the operating room. She has several comorbidity to begin with, and Cipro and Flagyl is not a broad spectrum antibiotic, and I think I would change that. And I don't know whether they did any blood cultures on this patient or not, but I think the appropriate antibiotic this patient would be in a case like this most likely would be Zosyn plus or minus vancomycin. So in the operating room, I think I agree with Dr. Untrack. I would do a limited resection, and I would resect the perforated area of the ileum and part of the ascending colon, and I would not do a Mikulicz type of a procedure here. I would bring them out as a double barrel ostomy, one in the right upper quadrant, one in the right lower quadrant, separate from one another. And then I agree with Dr. Untrack again, a very thorough, generous 6-7 liters of abdominal washout, and close the subcutaneous tissue, as close the fascia, leave the subcutaneous tissue, and this can open. Thank you.
Thank you, Dr. Kasim. Sao Paulo, Dr. Calais, your comments, please.
Okay. In this situation, I have sometimes have problems with the diagnosis of the disease in these patients. Patients that HIV has a hepatocolite and have divergence, obesity surgery. In this situation, you can see the abdomen. It's clear that the patient need to be resuscitation to put in the OR, not put the patient as I live. Put recover the hemodynamic stability. Try to start with antibiotics and then put in the OR. In the OR, you find the perforation, this position, because some people with immunosuppressive patients maybe are disease, some virus, some intestinal viruses has cytomegalovirus, may become some injuries in this situation, and maybe difficult to disease that is only this perforation, and then this perforation become other perforations on the next times in the postoperative day. So in these situations, I make resection of the ileum, where is the perforation, sometimes maybe resection of the column, the small resection of the right column, and staple the column, put a ileostomy, and close the abdomen. And if the patients need, I come back to review the abdomen. Usually, these patients can be closed and need a laparotomy on demand. That's the way I do in this situation.
Thank you, Dr. Calais. Curacao, not much longer. Dr. Frisbee. You're muted, sir. There we go. Thank you.
All right. You know, about a week ago, Alex, we had a 50-year-old with scleroderma and was on massive amounts of prednisone and solumedrol and came in, and the medical people got her to us after about 4 days of hemming and hawing. And when we did the emergency operation on her, we had an NG tube looking at us. So apparently, this is not very uncommon. In answer to your question, you wash this belly out because it's going to have trash and junk and everything else in it as rapidly as you can. And I would do a limited resection, close off the colon at this point, just staple it off and bring that ileum out as an ileostomy. Get out of there as quickly as you can, because you're going to have to go back in no matter what. These patients who've been on steroids for such a long period of time, we have found that in some instances, if you can't get the abdomen closed down here, we use a Bogota bag. We don't have any fancy $1,500 a shot, vacuum assisted things, but we use a Bogota bag. And at this point, if you can close her abdomen, I'd leave the skin open and close the fascia, close the peritoneum, but I would bring that ileum out as an ileostomy. That's all I've got.
Thank you, Dr. Frisbee. Dr. Ajaj, your comments, please. Dr. Ajaj. Dr. Calderon. Dr. Marttos, your comments, sir.
I had a problem with connection. I lost the part of the presentation. I'm gonna keep going.
Okay, very good. Yeah, let's see.
Gary, I have a question. It's Alon from Israel, from Jerusalem.
Yes, sir, Dr. Schwartz. Please be mindful. It looks like we're waiting for our presenter to reconnect. So if you can just address it to the group while he reconnects.
Yeah, so I have a question for Dr. Frisbee. In this case, when the patient is on steroids, do you use retention sutures? Like you close the fascia, you leave the skin open, of course, but will you use retention sutures to prevent evisceration?
Usually, you're right. We would do that. In this instance, the patient was just in so much extremis. We left the abdomen open. We just used a Bogota bag. Her pressure was in the 60s, and oddly enough, it almost looks like a carbon copy of the presentation for today. I don't know why. I think it might be the steroids, but she's a scleroderma patient and is really in extremis at this point.
Can I just say, where was the perforation in your patient, Frisbee?
Oh, in the first portion of the duodenum. The NG tube looking at us. I don't think that anyone had the presence of mind to protect her gastric mucosa from all that steroid. At least in a review of the records, we didn't find it. So that's
just a comment about the fascial closure. For years, what the people that study this have always said is that if you do a mass closure, you know, proper mass closure, that the retention sutures, they won't really stop a dehiscence, but they'll stop an evisceration. And, you know, in cases like this, I think the biggest risk for an evisceration is and dehiscence is if you close the skin, then they get an infection that you don't see for a few days, and then that totally destroys the underlying fascia, especially in developing countries and patients who don't have access to care, and then it's just a mess. So, you know, I agree with everyone else. Just leave the skin open, and in this case, I would have done a proper mass closure, and then if it opened up, okay, then we'd have to go back, you know. But I think it's perfectly reasonable to put the retention sutures. Either way, I think it would be okay.
Is everything? I'm back. Sorry about the.
Okay, great.
I'll blame the internet because that's what it was. The patient did have blood culture sent. Her antibiotics were brought. It was vancomycin and zosyn that she received, and then I performed right colectomy. I went maybe a little bit more like a extended right into the mid-transverse colon, basically. I left the GI tract in the discontinuity. I was worried about her being on steroids, and I had an NG tube in the small gastric pouch, and I placed that to suction. There wasn't much coming out, but I also insufflated with air, and I just wanted to make sure, see if there is any bubbling or if she has something else going on with that pouch. And then I did a damage control abdominal closure with Aptera wound vac. I left her in discontinuity. I did not, because I wanted to go back and wash out, make sure there's nothing else going on there. And she was really sick. She did get platelets in the operating room, and now we're back in the ICU for resuscitation. And questions now: when do you go back for second look? You wait 24, 48 hours, or you go by other clinical parameters to decide your timing? And when you go back, what is the operative plan? You know, primary anastomosis or diverting ostomy. Now, maybe some of these questions were answered with the first slide with questions, but with the internet being dropped, I'm sorry that I'm repeating myself if that's the case.
Perfectly all right. Dr. Frisbee in Curacao, your comments, please.
Alex, I use two criteria. We try not to touch these patients for about 24 hours because it's just too early. And the second criteria is the clinical picture of the patient after resuscitation. We're trying to warm them up. We're trying to give them enough fluids, and we're also trying to replace their platelets and their blood volume at this point. I would think around 36 to 48 hours, I would think about going in there for a washout if the patient's blood pressure had stabilized and you had a better picture of what her clinical status was. I'd say somewhere around 36 to 48 hours, just take her back and wash her out and see how you're doing. In the case of our patient, she was in no way, shape, or form ready to have a definitive procedure. So we put the bag back on and continued to resuscitate her, but we had our first washout at about 36 hours.
Thank you.
Thank you, Dr. Frisbee. Sao Paulo, Dr. Collette.
The option that you have to do is stay the abdomen open and review. It's a programmed laparotomy in this situation. It's a peritonitis, so different from the damage control. You have to program a new clear out the abdominal cavity. So you have to go 48 hours of the surgery, can see clear up the surgery, and then you can see what's happened. In this situation, you can try to make a primary anastomosis or diverting stomy. It's very difficult to decide in this moment because you need to know the etiology of the perforation. Sometimes the perforations may come from cytomegalovirus, may become a new perforation. Some perforations comes in this situation, maybe tuberculosis. Here I can see some people have tuberculosis, intestinal tuberculosis. If you make a reconstruction, you have a problem in this reconstruction. Different from the trauma, the situation is you need to know sometimes the reason for the perforation and to reconstruction. In our service in São Paulo, using the peritonitis, acute peritonitis for programmed laparotomy like this, sometimes you don't do more because not need. Some people, if you have put the intestinal put ostomy in the first surgery, and you can surgery may become on demand if you need, so you can close the patient. Different from the others, I close the abdomen, and the experience that I have, there is no infection on the subcutaneous. If you have, you can open the subcutaneous, like appendicitis, complete appendicitis with peritonitis. You can don't take the subcutaneous open. So in these situations, I believe if the option was review as you do, 24 hours, can see the cavity, the hemodynamic stability of the patients. And in these situations, I believe in this patient, I try to put iostomy.
Thank you, Dr. Clay. Portland, Dr. Kasim.
Alex, you have done stapling of the ileum, stapling of the colon, and then you took the patient to ICU. Am I correct?
Yes.
So, well, in the ICU, I would continue with resuscitation, and I wouldn't be in a hurry to go back to the operating room anytime sooner than at least 48 hours. But then I would depend on two other factors as well. I will probably look at the serum lactate, and I will also look at the procalcitonin. If I would have done a procalcitonin when she was in the ER or on the floor before our patient had surgery. So those two things would be very helpful to me if they are coming down, and then I know the patient's sepsis is getting under control. And then I agree with Dr. Frisbee, 48 hours. That's about the time that I would start thinking of going back for further washout. I would do a thorough washout, and at that time, I have to make a decision whether I want to do an ileostomy and leave the staple colon alone, and then again leave the abdomen open after closing the fascia, and not in a hurry to close the skin and the subcutaneous tissue. And also, I would like to add massive doses of vitamin C and vitamin A. It's been shown in patients who have steroid dependent. These two vitamins are markedly low, and they probably help in healing as well. Thank you.
Thank you, Dr. Kasim. And Iraq, Dr. Untrat.
Yes, I agree with Dr. Kasim's point about the lactate level, and procalcitonin is fine also. But if the lactate level was decreasing and she was getting better, then I would optimize her condition for a few days. If during the first 24 to 48 hours she was not getting better, if she's getting more acidotic, and you said she was coagulopathic, if she hadn't turned the corner, then I would be more inclined to go back sooner. This is not really like a case of ischemic bowel where you really have to go back the next day to see what's going on. But if she turned the corner, then I think you have a few days to optimize her condition. And then in the operating room, I would, in this case, I would not do an anastomosis until she was all better. She was treated by the HIV specialist, her CD4 count returned to something more reasonable, and she were well nourished. And then I would consider doing a full anastomosis. And also I would still close the fascia, but leave the skin open, because in HIV patients, often you won't have the signs of erythema and duration of an infection, and it may just, you may get an infection that'll, again, extend deepward and destroy the fascia, and then and you have a bit of a difficult situation on your hands. I think it's just as easy to leave the skin open. But so in this case, I would do a stoma. If everything looked okay and you thought that the sepsis were under control, I'm a fan of doing double barrel stomas, or miculate stomas, really double barrel stomas, simply because the final operation would be a more local one without having to go back in and go through lots of adhesions and put the patient at risk for another complication. But I think either way is okay, although I wouldn't do an anastomosis and I'd leave this.
Thank you very much, Dr. Untrack. Does anyone else have a comment before we return to our presenter? Back to you, Dr. Alex.
Okay, if we can please advance the slide. Thank you for the comments and the insights. So I did not have procalcitonin checked, but her lactic acid started to improve. Hemodynamically, she was doing much better. And what I did contact her gastroenterologist, and he gave me some information about her last colonoscopy, which wasn't terrible. I wanted to speak with him because my concerns were, okay, what am I doing with this? You know, what if this is becoming some sort of a, you know, fulminant colitis? Now I leave a piece of colon over there, and later down the road she's not getting better. So my plan was to, you know, when I do the second look, to basically you know, do an endoscopy and actually look at the gastric pouch. Can we go back one slide? Okay, this is the slide that I'm looking for. So her creatinine was coming down to 2.5, vital signs improving. So I took her back. It was a little more than 24 hours for the second look. And at the second look, I plan to do an endoscopy, maybe put a colonoscope and make sure the colon looks okay from the inside. And basically, I removed the Apterovac. I washed the abdomen. There was just serous fluid. I gave a really good wash. Probably ran out of warm saline at the first OR case after I washed her. And when I put the scope in the gastric pouch, I actually saw air bubbling in the upper abdomen. She did have the history of Roux-en-Y gastric bypass. So air was bubbling in the upper abdomen, and the left lobe of the liver was kind of obscuring that. And I was like, just to have an NG tube and insufflate with air and fluid, that may not be enough to diagnose something like this. So she had a gastric pouch perforation at the gastrojejunostomy site. So how do you address this new finding, and what would be, like, you know, would be repair or just resect it and redo it? And then for the colon and the ileum, you know, I think overall the consensus is to just leave her in discontinuity with mucus fistula and endoleostomy. But you know, having to do 2 anastomosis in somebody who's septic and sick, how would you tackle this situation?
Israel, Dr. Schwartz, your comment, sir? Dr. Schwartz, Sao Paulo, Dr. Calais, your comments, please.
Yes, in the situations, I don't make, I try to close the perforation of the gastrojejunostomy in the site. Suture, I put a EpiPen patch and put a ileostomy and drains. That's the way I do.
Thank you, Dr. Calais. Is that the extent of your comment, sir?
Yeah.
Okay, very good. Dr. Kasim, in Portland, your comments, please.
Well, I don't think I would be heroic, knowing that this lady is very sick still, you know, even though her parameters are coming down. I think to take down this anastomosis is going to be rather taxing to my heart, at least. I think I would keep it simple, you know, the KISS principle. Repair the perforation, buttress with viable omentum, lots of it in that area, and patch it, and then when you finish, say a prayer. I think that's all you can do.
Thank you.
Thank you very much, Dr. Kasim. All right, Dr. Untrack, your comments, please.
Yes, I agree with all those comments. And I think Dr. Lett said leave it drain. It's basically a side fistula. So a nice suction drain that if it leaked, you'll see it on a contrast study and you'll have a controlled fistula that'll just seal off. And I don't do this operation, so I assume that that's what the bariatric surgeons would recommend. But I agree with the other comments. Don't be heroic. Don't, as you said, the enemy of better. The enemy. What you said before. It's the same thing here. You know, and I, as you said, stomas. And again, I think that, you know, it's if you're really if the patient is really an extremist, you know, you leave the one end in or you bring them out separated. But if the patient is doing better and you have some time, I just think it's make it easier for the third operation if you know you didn't have to do a full laparotomy, lysis of adhesions, and you know, and you can just do a smaller local operation to reestablish continuity. So, but it's just personal bias.
Thank you, Dr. Ontrack. Can we go to Curacao for Dr. Frisbee's comments?
Well, I agree with Kasim. I think the more you do, the worse off this patient's going to be. I would close off that perforation if I could find it and just wrap it up with as much omentum as I could find and just get out of there. She's going to be sick for a long time, and this business of steroids and anastomoses, they're always at odds with each other. The more steroid on board, the less chance that anastomosis is going to hold. It'll probably break down on you, which may have been the etiology of this whole thing in the beginning. But be that as it may, that's what I would do. I think Kasim's got the right idea.
Thank you very much, Dr. Frisbee. Any other comments before we return to our presenter? Okay, back to you, Dr. Alex.
Thank you. Let's advance one slide, please. So at the second look, I did the EGD. I repaired the gastrojejunostomy primarily, and I did find some momentum, and I buttressed the repair. I put a feeding tube, a G tube in the gastric remnant, and I performed an endoleostomy and a mucus fistula. We went back to the ICU for ongoing resuscitation, and I have now the pathology report of the first operation where I took her right colon out, and it showed perforated internal ileum with fissures, ulceration, transmural inflammation, abscess formation, and then the appendix had reactive serositis. So this was kind of an odd presentation to really have two holes in your GI tract, but the way I put it together in my mind now is probably she had this colitis going on, which was treated with steroids. With the symptoms she had, she stopped taking her medications. CD4 count went down, created a situation where she's at risk for typhlitis and whatnot, and she perforated internal ileum, sort of walled off by the rest of the intestines. And then the steroid dose being increased negatively affected her gastrojejunostomy at the pouch. That's what I think happened. And I'm glad I looked in that pouch. It was really not, it didn't take longer in the operating room, but I think if I wouldn't have done that and I would have just closed her mucus fistula endoleostomy, she would have ended up back in the unit, still sick and not getting better. Valeria, can you advance the slide, please? Now we're in the first week, she came off pressors, heart rate is better, creatinine is 1, platelets are coming up, lactic acid 1.9. I did give her vitamin A and multivitamins, but I did not give IV vitamin C, but I'll keep that in mind for future. She was tolerating her 2 feeds, and now ileostomy was behaving 1.5 liters per day. And now kind of the moment of truth, you know, time for upper GI series and additional imaging. And some of you anticipated what the findings are going to be. Valeria, can you advance the slide, please? And now we have the leak. the gastrojejunostomy repair, which failed because of all the reasons that everyone outlined. But now she's also tachycardic in 120s. The CT scan basically showed that the leak was controlled by the drains. Her Y count and physiology, other than the heart rate, with her being off pressure, doesn't suggest that she is septic. And I worried about things like PE and DVT. So we did an ultrasound bilateral extremities showing bilateral DVTs and a CT angiogram of the chest showing bilateral PE. So she was started on heparin drip at this time, and she continued with antibiotics tailored by ID consultants, and they started her on her HIV medications. Can you advance the one more slide, Valeria? You can see the drain, the repair, contrast, extravasation over there. And can you advance one more slide? Now on day 13 to 17, her tachycardia improves. The leak is contained. She's on vancomycin and fluconazole and her HIV medications. And we had a discussion with her other consultants and doctors, and we decided she may need additional IR procedures. We may need to stop heparin drip for different procedures. She actually got an IVC filter placed and continued with the heparin drip. 24 hours after the IVC filter was placed, the morning I came, patient was hypotensive. She was bleeding from the midline incision. Hypotensive again, tachycardia 150s, hemoglobin drop. Her PTTs were supratherapeutic, but not terrible. But we had three number 100, 117, and 102. So the heparin drip was held, and all the drains were kind of bloody. So the question now is, where is she bleeding from? Should we go back to the operating room or just kind of hold the heparin and transfuse? And if we go back to the operating room, should we go after this gastrojejunostomy failed repair or not? So if you can comment on these two questions. Thank you.
Sir, let's go to Iraq. Dr. Untrak, you have comments, please?
Yes, I think once you put the IVC filter, because she was bleeding, I probably would have stopped the heparin. And then now that she's very hypotensive, I think I would still try that, transfuse her. Platelet count is okay still? I assume it's okay.
Platelet count 359.
359, okay, so it's okay. And I would try to see if you can reverse the hypotension by reversing the anticoagulation and some transfusions. And then if not, I suppose you'd have to go back in the operating room, but I would not. I would do everything I could to stay away from the repair gastrojejunostomy at the pouch. And what I might do if there were time is repeat the study, repeat the gastrographin study and see, is it still the same controlled fistula, or is it now, did the whole anastomosis fall apart? You have now two ends that, that you'd have to definitely go in and deal with. But barring that, if the fistula was still controlled, I would certainly stay away from the anastomosis, stop the bleeding, see if it can reverse the shock. And so far, this looks like not sepsis, but just coagulopathy and bleeding from that. And her, did you mention the lactic acid level at this time? Was it okay?
It was elevated a little bit.
Okay.
But I can't remember from the top of my head. I think it was up to 4.
Well, it's significant, but it's not what it was before. I think you said it was 20 before, whatever. So I would try and see if you could avoid wait 6 hours, see if you can turn things around with transfusions and stopping the heparin.
Thank you, Antrat. Curacao, Dr. Frisbee.
Yeah, I wouldn't be in a hurry to get back to the operating room, not in the presence of all that. First of all, you're never going to find out where it's all bleeding from because it's bleeding from everywhere. So stop your heparin, and if you need to give some protamine, do it. But I would be a little bit, I'd have a little bit of patience to see if I couldn't transfuse her back up and see if that bleeding will stop. what are you using to control the gastric mucosa? Did you give her anything like a protein or a proton? Okay.
She was
So
on protonics.
Yeah.
Twice a day, IV.
Good, because down here they forgot it. At any rate, I think Dr. Untrek is right. I would hesitate. Don't run back into the operating room just yet. Let's see if we can't transfuse her up and stop that heparin, see if she'll stabilize at this point. But that's my only comment.
Thank you, Dr. Frisbee. Let's go to Portland. Dr. Kasim, your comments, please.
Because Alex says that all the drains have blood in them, that makes me think this is probably coagulopathic bleeding rather than something in the abdominal peritoneal cavity. And I concur with my colleagues. Although I am a very aggressive surgeon, I think I will probably hold my horse for a while, transfuse, reverse the coagulopathy, get consult from the hematologist to see if he has any smarts under his belt, and give her a little longer time to see if she stabilizes. And if she does not stabilize and if he's trending downwards, then I have no choice to go and have a look. Thank you.
Thank you, Dr. Kasim. Sao Paulo, Dr. Calais, your comments, please.
Yes, I agree with all comments in the situations, bleeding for all drains and the abdominal incision. You can try to control the coagulopathy in this patient and wait for the surgery. If it is not possible to control, stop bleeding with control the coagulopathy, you can go to the surgery, and that's the way I come. They ask you have heard about the gastrojejunal link. In this situation, it's very difficult to repair this link in this moment because the surgery to repair this link is very big. Then the patient can be need or can be the metabolic disease can in these patients to do this surgery. When you do the surgeries, the patient may be a recidive of the link. So it's very, the surgery may be bigger. Sometimes you have to resection the small the gastric anastomosis and the gastric pouch, and it's very difficult to repair and reconstruction in these situations because very little. So in this moment, if you go to the surgery, you can wait for the correct the link, only drainage.
Thank you, Dr. Calais. Do we have any other comments before we return to Dr. Alex? Okay, back to you, Dr. Alex.
So thank you for the comments. I started with resuscitating her, work on correcting the coagulopathy, and then repeat exams. She still had basically drainage from the midline, and it was bloody. It was blood coming out, and it was kind of odd the timing of this, like right after the IVC filter was placed. And I worried about that, and I actually took her to the operating room by a few hours. It was like around noon that day when I saw her in the morning. I looked at her zones in the retroperitoneum where she had, IVC filter was placed. I worried about some disaster happening with that. So that all looked good. There was a lot of fresh clot underneath the abdominal wall, and I found the rectus fascia tore and the rectus muscle, and she basically, that was the only source of active bleeding that I saw. So I removed the old clot and some other fluid that she had in the pelvis. In the right upper quadrant and left upper quadrant, there was no hematoma. So my procedure was exploratory laparotomy, hematoma evacuation. I closed the abdominal wall with vicryl mesh and retention sutures. And I placed more drains, and I did not touch that area of the failed GJ repair because I was worried that I'm just going to make it worse and not make it better at all. If we can move, advance one more slide. So this is how I did the retention sutures. Basically, there are 5 in total, but I basically put maybe like 1.5 centimeters to 2 apart, and then I tied one end. Before I tied, I put a folded 4x4, and then I had the assistant hold this other side. I put another folded 4x4 and I tied on top of it. So basically what this allows me is just pull one end, change the gauze when it's dirty, and then pull the other and then change the gauze. And also allows me access the midline instead of having the retention suture kind of come across, and then I can put a wound vac. On the right side, this is the end ileostomy. On the left is the mucus fistula, and you can see the plastic disc from the G-tube. Can we advance one more slide, please? Now we're basically getting close to 4th week. She's back in the ICU, vital signs normalized, platelets took another dip, but not lower than 109, hemoglobin stable, 2 feeds are at goal, ostomy staying at 1 liter a day. She's on the same antibiotics per ID, and we're doing better. Can we advance one more slide, Valeria? And, you know, the dreaded gastrographin upper GI series again. And you can see her albumin really didn't really budge. I mean, from 0.8 up to 1.1, pre-albumin 10.4, the highest has been. She has 4 drains, and she has a persistent leak. The CAT scan performed showed that there is, you know, contrast pooling in the anterior to the spleen, but it's not leaking freely in the abdominal cavity. Can we move one more slide, please, Valeria? So now, even with that poor nutrition, she was able to heal. And, you know, a couple of points, the gauze that I had here basically kind of created a little bit of pressure. Necrosis, so I removed all the retention sutures except these 2 here. And what we ended up doing with the wound care nurse, basically we wrapped the 4x4 in duoderm that causes less pressure on the skin. So now I've kind of finally got her to heal a little bit. This is the mucus fistula and the ileostomy here on the right side. So what would you do at this time? Return to the OR, really do repair the gastrojejunostomy, or any other options or thoughts in this case?
Let's go with Portland. Dr. Kasim, your comments, please.
Well, you've done very well so far. You know, you're almost there, 90%. So you have one last hurdle to cross, which is the leaking GJ. I think I would get help from an advanced gastroenterologist if he has any thoughts. I remember some time ago, like a couple of years ago, Dr. Super presented a case like this where he put some type of a stent in or a plug in the duodenal leaf and got the patient healed. I think I would be very leery of going back to the OR at this moment. Is she on TPN?
No, she's not on TPN. She's tolerating the 2 feeds. 2 feeds are at
2
goal.
feeding, right. So as long as you are nutritionally supporting her, you know, one of these days, I am pretty sure if there is no distal obstruction, I think she will heal this fistula. I think I would be very, very reluctant to do any type of operative procedure on her at this moment. I think you have done exceptionally well. I think I would hate to think that you would spoil it by going in there and getting into trouble. Thank you.
Thank you.
Thank you, Dr. Kasim. Sao Paulo, Dr. Calais, your comments, please.
Okay, I agree with the comments. I believe that patients at this moment not need to go to OR, can wait because the inflammatory procedures in the abdominal cavity may be very difficult to repair these injuries at this moment. We have to wait, nutrition the patients, and then when the patients can be stable and nutrition can go up. The gastrojejunal fistula, if they are a trajectory, it's a linear trajectory, sometimes it can close it. only if with the support nutrition. And so at this moment, that's the way I well.
Thank you, Dr. Khaled. Let's go to Iraq. Dr. Ontrak, your comment, sir?
Yes, to paraphrase, maybe you didn't know, you weren't here back then, but to paraphrase Ryan, I think that leak of the gastric pouch is big enough to take care of itself. So I would not go back to the operating room for that. And I think if you restudied her now, maybe you've done this, that would be a pseudodiverticulum that'll just drain itself back into the pouch and then it'll close or out through the drain. And then if it doesn't do that, it might be sort of just a collection, a fistula with an associated collection, and the interventional radiologist can probably reach that and drain that for you to make it go away. And then you'll just have a side fistula that's well drained through your drains and also the radiologist drains, and then it should close with proper nutrition with time. But I think that really you're way ahead now, and I think going back, there's a big risk that you take a few giant steps backwards. So, and I agree with what everyone else said. One of the point that in the last operation that you did, depending, I wasn't there, but sometimes you go back in, you just see a hole in the bowel or anastomosis within operation, and it's pretty sizable. And so you put the extra drains on the outside, and sometimes what I do in that case is to put a small Foley catheter or similar drain through the perforation and then gently inflate the balloon just to minimize the amount of leakage past it, and keep that drain either on suction or on drainage of very, very light intermittent suction to keep the inside of the pouch closed. And then that will sometimes form a direct fistula through the drain with no leakage around it. So that the drainage out the outside drains will stop, and then you'll see some maybe GI contents coming out through that drain that's intraluminal. And then if the upper GI the gastrographic studies don't show any additional leakage, you can take that tube out inch by inch to deflate the balloon, advance the tube out, and then the fistula tract will close, just like a T-tube. When you do a common duct exploration, it'll just form a tract and close. But I think it's a great job with that very difficult case, and you're way ahead.
Thank you, Dr. Ontrak. Curacao, Dr. Frisbee, your comments, sir.
I agree. Alex, Dover has a really good place where you can surf cast if you're a fisherman. You need to go there and leave this lady alone, because she's eventually going to, that fistula, as long as there's no distal obstruction and she's got good nutrition, that thing will close. Just patience, my friend. She's been on a lot of steroids. It's going to take a long time. But I think you're doing a great job. Real nice job.
Thank you, Dr. Frisbee. Any additional comments before we return to Dr. Alex? Okay, back to you, Dr. Alex.
So, Dr. Frisbee, how do you know that I just got my my drive on the beach tag? But yeah, so I agree with all the comments, and yes, the time for an advanced endoscopist or somebody who can either put a stent or some other type of interventions. And I think I got a little lucky here, because we had just started a surgeon who actually had bariatric expertise, started taking calls at the hospital kind of right around this time when I was kind of in this phase with this problem. And I went and I talked to him, and I said, I've been reading about, some different options, and, this is how things look like. How can we, help this lady? So basically, Valeria, can you advance, please, for me, the slide? So basically, what is available is this Ovesco clip technology. It looks kind of like the metal kind of bear trap, where this device is used to deploy the clip. It has this tip here like a tripod, where this is advanced in the middle of the tissue or the defect for a leak that doesn't heal, or a fistula. but it's within reach of the endoscopy. And then these two metal parts kind of grab the tissue close to this midline, and then this metal piece gets kind of pulled into this plastic device here. And once the tissue is here inside, then the stent is deployed. This is done in the operating room, and he placed 2 of these clips, and we restarted the 2 feeds via the G tube. We took out the NG tube, and then the drains were monitored. Can we advance the slide again? And this is close to basically 45 days, but she's doing well with 2 feeds. I think 3 days after the procedure, it was 3 days after the procedure, we did another CAT scan with oral contrast. And I thought all the prayers were answered because there was no leak at this time on this CAT scan. Can advance 1 more slide, please? So right now we're doing better. She's on bariatric soft diet. She's also getting 2 feeds. Albumin and pre-albumin are moving in the right direction. She still has the IVC filter, Lovenox for prophylaxis. The IVC filter is retrievable, so the plan with that later down the road would be to remove it. And she still had 1 drain left, and eventually she was discharged to rehab. So that's my disaster case. Any comments? Any questions? Thank you.
Thank you, Dr. Alex. Curious how Dr. Frisbee, your final comments, please.
Nicely done. Very well. Just remember, any plane crash you can walk away from is a successful landing. This is really, really good job. Nicely done.
Thank you.
Thank you, Dr. Frisbee. All right, Dr. Untrat, your comments, sir?
Yes, so if I understand correctly, then that clip is basically closing the perforation from the inside, from inside the lumen. Is that right? Yes.
Correct.
It looks like it worked for you. For the same reasons that the last repair failed, I probably would have opted not to do that. I would have maybe gone, if necessary, with the interventional radiologist if the repeat study showed that the collection didn't disappear or it had gotten bigger. I would have done it that way, but it seemed to work for you. So, you can't argue with that. So, but anyway, well done. Great case. And there you go. So Philadelphia is going to be lucky to have you.
Thank you. We did talk about options to, maybe place another drain with IR. He was saying this is successful and it works pretty good. And the other option, he said, sometimes there are some situations where he had success with, with an NG tube, with a sponge at the tip, advanced in the actual defect and leak, and that be placed to suction, so it kind of sucks the tissue close together and then makes it smaller, the defect. But yeah, we did go with the Vesco clip.
Yes, but well done. Nice result.
Thank you.
Thank you. Sao Paulo, Dr. Calais, your final comments, please.
I have to comment. That's a very, very great case. It's a very difficult case to treat when we have these fistulas. And thank you for the presentation and share your experience with us, Alex. Thank you.
Thank you, Dr. Calais. Portland, Dr. Kassim, your final comments, please.
Alex, this is a very, very good educational case. And I learned a lot. And one thing I learned here is patience. Like Dr. Frisbee says, you got to have a lot of patience in treating patients like this. The young guys who are coming out of residency nowadays, and they are really mastering the endoscopic maneuvers of GI tract. I recently had a problem with my small bowel, and endoscopies were able to go per oral to fix it, and successfully. So keep that in mind. Sometimes it is worth talking to the the young endoscopists in your team, and they may have the solution to your problem. Well presented, well executed case. Thank you so much.
Thank you.
Thank you, Dr. Kasim. Any other comments? Dr. Marttos?
Yeah, so when Alex spoke to me about this case, it was a great case, and I'm very glad, happy to see his growth professionally. He was a great fellow here, had a fun time here with us. And Alex, congratulations on finishing this phase of your career. And I wish you just the best in your new phase. And we are very happy to have you here every week. Okay, thank you. I know you have another good case to present us in a few weeks. So that's the way to go. And Dr. Utrecht, if you have any good case from overseas, let us know also. It'd be nice to have some presentation for you also.
I might have one of neck trauma, but I'll send you the chart. You can look it over. Okay.
Perfect. Okay. Thank you all.
Thank you.
Next week, Valeria, next week, Dr. Schwartz is going to present, correct?
Correct.
Yeah, so next week, we're going to have a presentation with Dr. Schwartz from Israel. Thank you all. See you all next week. Take care.